And Kevin did my job a little bit in that last answer, because the next two speakers that I'm going to invite to the stage include Dr. Brad Langford. Dr. Brad Langford and Dr. Larissa Matukas are our next two speakers. Brad Langford is a board-certified infectious disease physician and antimicrobial stewardship pharmacist specialist at Public Health Ontario and Hotel Dieu Shaver Health and Rehabilitation Centre. He's also an assistant professor at the Dalla Lana School of Public Health at the University of Toronto and associate editor of the Journal of Antimicrobial Stewardship and Healthcare Epidemiology. His practice and research interests include antibiotic use and resistance surveillance, knowledge translation, and implementation science in antimicrobial stewardship. And he's joined for this session by Dr. Larissa Matukas, who's an associate professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto, head of the Division of Microbiology at Unity Health Toronto, and an infectious disease specialist at St. Michael's Hospital. She is the current president of the Canadian Foundation for Infectious Diseases and the chair of the Institute for Quality Management and Healthcare Bacteriology Scientific Committee. Her specific area of interest and expertise are in microbiology quality improvement, application of novel diagnostics, laboratory and antimicrobial utilization, and stewardship and antimicrobial resistance. She's been sought out as an expert to contribute to guidelines on implementing quality management systems in microbiology laboratories, best practices in specimen collection, choosing wisely Canada for microbiology, and provided microbiology expert experience and guidance to the Ontario Ministry of Health. We're getting to that point in the day where even reading a bio is tripping me up, so my apologies. Larissa and Brad are going to give us an interesting perspective on NIMBLE ways to steer antimicrobial prescribing. So come on up to the stage, guys.
Thanks so much for the introduction. It's a pleasure to be here and present to you about nudging in antimicrobial stewardship and prescribing. So our objectives for this talk today, we're going to talk a little bit about cognitive biases and how they relate to antibiotic prescribing. We'll give you some examples of what we mean by the concept of nudging. And then Larissa will talk to you about some antimicrobial stewardship strategies that we can use and apply in the microbiology laboratory to improve antimicrobial use. Before we get into things, I wanted to highlight this important work by Dr. Daniel Kahneman. He's a Nobel Prize-winning behavioral economist and psychologist, and he's done some nice work to describe the different ways that humans think. He describes these two modes that we shift between as type 1, which is more fast and intuitive, and type 2 is more slow and deliberate. Because of evolution, we've evolved to spend most of our time in this fast and intuitive mode, where we're making these everyday decisions, thousands of decisions a day. It's quite automatic. So if I was to ask you, what's 2 times 2, you'd be able to rhyme that off very quickly. The challenge, though, is this is more prone to bias. So we have these mental shortcuts or heuristics that we use, and they can be introduced into our everyday decision making. On the other side, we have this type 2, which is more slow and deliberate. As I mentioned, this is used less commonly. We have to reserve it for more of our complex decisions because it's more effortful. So something like 17 times 24, most of us will have to sit down and think about what that is. So keeping that in mind, let's go through a couple of exercises to illustrate how or if we all have some cognitive biases. So this is the first exercise and to ask you, if a random word was taken from the English dictionary, is it more likely that that word is going to start with the letter K, or is it more likely that that word is going to have letter K as the third letter? So by show of hands, how many think it's letter K as the first letter? Okay, so it's about, 30%. And then how many think letter K is the third letter was more common? And that's probably like 40%, 30% non-participation, I think. So those of you who said letter K is the third letter, actually that is correct. That's about 3 times more likely than the word that starts with the letter K. The challenge is if you ask most people this question, most people will say letter K is the first letter. It's easier to think of words that start with the letter K. It just comes to the top of your head, right? Kick, kangaroo, kaleidoscope, those kinds of things. But it's hard to think of a word that has letter K as the third letter. So this is an example of availability bias, and we tend to overestimate things that are more easy for us to recall. And so this applies certainly in medicine and prescribing too. If we've had a particularly difficult case or something that's been maybe traumatic for us to deal with, we tend to overestimate the prevalence of that event happening again. Okay, one more exercise, and this is called the Wason card selection task. So we have 4 cards down on the table, A, D, 4, and 7. Each of the cards has a number on one side and a letter on the other side. So the question to you is, which of these cards do you need to turn over to prove that this statement is false? And the statement is, if a card has a vowel on the one side, then it has to have an even number on the other side. So again, the statement, you want to prove the statement false, is if a card has a vowel on one side, then it has an even number on the other side. So I'd like to hear what the audience thinks in terms of which cards do you need to flip over. You can choose as many as you like. How many want to flip over card A? Okay, so there's a few people there. How many want to flip over card 4? Okay. Anybody want to flip over 7? Okay. Anybody A and 4? A and 7? There's a very few people who think A and 4 and A and 7. Most people said either A or 4. The correct answer is actually A and 7. And when you ask people, most people this question, they will say A and 4. There's a tendency to try to prove the statement true, even though the question was to try to prove it false. And you can only prove it true if you flip over 4. So the answer has to be A and 7. And so that's a little bit of a tricky question, but there's an underlying bias that might be at play here. It's confirmation bias. There's a tendency to seek out information that confirms rather than refutes a certain belief. And again, this can certainly happen in the world of prescribing as well. We've described many of these potential cognitive biases that we see in antibiotic prescribing. In medicine, there's hundreds, but these are the things that we think are most common. In the interest of time, we can't go through all of these, but I will highlight a few of them. This is a visual abstract from our paper. And I'll start on the far right-hand side, which is present bias. And I think this is a tendency to favor smaller, more immediate benefits rather than larger, more distant benefits. So easier to just do something now. And I think that's an issue not only in antimicrobial resistance, but also in climate change, where it's hard to think about a more distal future and what might happen, and so easy to make those decisions now that may harm us in the long run. The IKEA effect, I think this is actually a positive bias because it involves placing a higher value on something that you were personally involved in building. So if you put something together from IKEA or otherwise, that piece of furniture, you tend to place a higher value on it than if somebody else had put it together. And that can be applied in the world of stewardship because we can involve people in the development of our stewardship initiatives, and those people can then go on to value them and become champions for that work. And then on the far left-hand side is commission bias. I think we've heard about this in some of the previous talks, is that there's this tendency to believe that more is better than less when it comes to antibiotics. So it's easier to start an antibiotic, but harder to stop an antibiotic. And we found this in one of our studies where this was at St. Joseph's Health Center where I used to work. We looked at 11,000 antimicrobial stewardship program recommendations where either the pharmacist or the ID physician was making a recommendation to the prescriber to improve or optimize the antibiotic therapy. About 82% of those were accepted, which is pretty standard for most stewardship programs for this type of feedback. However, if you stratify those recommendations into whether they aim to increase the exposure, whether they're neutral in terms of exposure, or whether they decrease exposure, you see this clear separation. The clinicians are much more likely to accept a recommendation that increases the exposure. Yes, it's okay, let's start antibiotics, increase duration, increase the breadth of the spectrum of activity, but decreasing the exposure, like stopping antibiotics, shortening the duration, de-escalating the spectrum, there's a bit more hesitancy there. So I think this shows you an underlying risk-benefit analysis that the clinicians have about the benefits of antibiotics seemingly outweighing their risks. So that's something we have to, I think, recalibrate with our work in stewardship. So what can we do about all these cognitive biases? There's a few different things. One is to slow down and try to activate that type 2 mode of thinking. So antibiotic timeouts is one approach that's been used. Say 48, 72 hours into therapy, there's a trigger for us to look at the patient again, make sure that we have our laboratory results back. We look at the microbiology results, et cetera, to see, does this patient still need antibiotic therapy? And that can be facilitated through checklists, through clinician-led prompting of prescriber. Another approach is to reflect. It's kind of like a metacognition approach, to think about the way that we think. This hasn't really been studied as much in stewardship, but there's approaches like considering the opposite. So using some mnemonics to try to think about other reasons why, say, a patient might have delirium. What are some other reasons aside from a urinary tract infection, so we're not narrowing down the scope too much? And then thinking about one's confidence in one's own diagnoses can maybe undercover some of your own blind spots or cognitive biases that you have. And what we're going to focus on is making it easy. So using forced functions, but forced functions could be something like, ensuring that there's always a specific duration in place or always a specific drug is used. This is a little bit more heavy-handed, but what we're going to focus on more is nudging, which is a bit more gentle approach. So this is the definition of nudge from the book Nudge called Nudge by Thaler and Sunstein. It's defined as any aspect of the choice architecture that alters a person's behavior in a predictable way without forbidding any options or significantly changing their economic incentives. So it's a bit of a mouthful, but I think in a simple terminology, it's gently guiding decision-making while preserving the user's autonomy. So some examples of everyday nudges: markings on the road, the alarm clock that wakes you up in the morning, packaging on cigarettes. These are all things that aim to try to alter or guide your behavior. You still have autonomy to ignore it. There's no incentives or disincentives to ignore it or to abide by it, but it does tend to align with your best interest or the best interest of society. This is the Newfield intervention ladder. It's kind of an example of all the potential the degrees of intervention that policies or decisions can have. So from the bottom, simply doing nothing, to all the way at the top where you're entirely eliminating choice altogether. And so, either end of the spectrum can be problematic. At the top end of the spectrum, because there may be pushback and may be very hard to implement some of those decisions, or you're completely restricting choice. But nudges kind of sit there right in the middle where the sweet spot is, where you can guide choice through changing the default, or you could argue that should say changing the choice architecture, that the way that choices are laid out for the clinician to make. These are a few different categories of nudges from a few systematic reviews from the literature. We won't go through all of them, but I'll highlight a couple of them. Default rules tends to be one of the most commonly used types of nudges. That's basically making the most desirable option the default option. So for example, in countries that they have organ donation as an opt-out system, so everyone's already automatically opted in, that system ends up with much higher participation in organ donation than if you had an opt-in system where everyone's opted out and they have to do paperwork to get in. Social norms, Dr. Schwartz just talked a lot about this. People aim to behave like their peers, and that's why prospective or audit and feedback and peer comparison works. And then I'll highlight pre-commitment nudges and making a decision, a desirable decision ahead of time. This has been used in some research contexts where posters that say we promise to use antibiotics judiciously within this clinic. We have the physician's image there, a photo of the physician, the signature of the physician, and it's posted in the exam room or in the waiting room. And this has been shown to reduce unnecessary prescribing significantly because it's a pre-commitment nudge on the side of the prescriber. They've agreed to do this ahead of time, and it's also a nudge to the patient around what to expect when they visit their clinician. So just a few things about what makes nudges work. I think this is an easy acronym to remember, and I try to think about this when we're doing any interventions. It's called the EAST framework, and each letter stands for a specific component of a successful nudge, and this is from the United Kingdom Behavioral Insight Team, or as they call it, the Nudge Unit. So E stands for make it easy in simplifying the default, simplifying and making the desirable choice the default. Attractive is attracting attention and providing rewards. Social is encouraging commitment and showing what model behavior looks like. And then timely is prompting clinicians when they're most receptive and consider immediate benefits. So usually for our purposes, it's right at the time of prescribing is when you want to prompt them. So just one final example before I turn it over to Dr. Matukas. This is a study that we did in Ontario where we looked at over 100,000 positive urine cultures from 48 different outpatient laboratories in the province. And we saw that there was a lot of variability in how laboratories reported their results. Variability in terms of the numbers of antibiotics that were reported in terms of culture and sensitivity, and also the difference in terms of the types of antibiotics that were reported. So lots of heterogeneity. But one thing that we did see was that when a laboratory showed a specific antibiotic on their report, the clinician was about threefold more likely to prescribe that antibiotic. It's kind of obvious, but it shows you the potential role that laboratories can play in antimicrobial stewardship. Whether they're thinking about it or not, they are nudging the clinician. So with that, I'll turn it over to Larissa to talk about some nudging strategies.
What button do I press? Just this one. Okay. So thanks, Brad. So Dr. Langford really nicely outlined a lot of the opportunities for nudging, and how we can apply those to microbiology is what I'm going to take us through. So there's a couple of ideas that we've been looking at to sort of think about how can we, as Dr. Langford just highlighted, how can we persuade or nudge or influence prescriber behavior based on how we report out microbiology susceptibility testing results. So there's sort of three different strategies that we have looked to the literature and that we ourselves are studying in order to understand what the impact of these different nudging strategies might be. So the first one is selective reporting. So selective reporting is reducing the number of antibiotics that are actually tested and reported out on a microbiology report, but selecting the most appropriate ones, the ones that are based on guideline or expert opinion. The next opportunity is to consider, well, maybe you still provide all of the antibiotics that you tested that are appropriate for that type of infection, but maybe instead you add a comment to the report to highlight what the preferred antibiotic is to treat that infection. And then the third nudging strategy to consider is eye level, which is kind of like going into like a cafeteria and you're looking to see what you want to actually eat that day, and they put out all the candy, so you tend to eat candy. So eye level is to put out the antibiotics that we think are the best antibiotics or the most appropriate at the top of the list in the hopes that somebody would actually choose those as the preferred antibiotic as opposed to the remainder of the antibiotics that are listed alphabetically after those ones. So if you look to the literature, we actually have tried to look at this, and so the example of selective reporting, Dr. Langford led a group when we were at St. Joe's Health Center, and we modified the microbiology report. So typically in urine cultures, we would report out ampicillin, ciprofloxacin, Septra, and nitrofurantoin. And what we decided to do is, well, fluoroquinolone use is probably not the best agent to use all the time. We probably should be restricting it. It has a lot of harms associated with it, a lot of side effects. So let's just stop reporting it on urine cultures and see what happens to prescriptions associated with ciprofloxacin. And what we notice, so you can see in this graph, the dark black line is DDDs per 1,000 patient days of ciprofloxacin use. And you can see how nicely pre and post that it really nicely declined, and this was quite significant. So ciprofloxacin use can actually be curtailed if you actually stop reporting it on the microbiology reports. What I'll just highlight, though, is that just like with any other intervention that we put into place, you need to be aware of sort of the unintended consequences sometimes of these types of interventions. And in this case, if you look at the sort of solid gray line, you can see that that is actually representing an increase in antibiotic use of amoxicillin clavulanic acid to treat these urinary tract infections. So it's a little bit of a squeezing balloon effect, but certainly it shows us that selective reporting of antibiotics on a microbiology report can actually influence prescriber behavior. The other example that I was discussing was framing. So framing is adding that comment to the report to basically tell or provide clinicians additional information in order to choose a more appropriate antibiotic, or even to whether or not an infection actually needs to be treated. So I think one of our speakers yesterday, Dr. Daly, actually led a study in Newfoundland where they actually hid all the susceptibility results for urinary tract infections, or urine cultures, I should say, and they added a comment to the report that said, the majority of positive urine cultures from inpatients without an indwelling urinary catheter represent asymptomatic bacteria, and you had to call the lab if you really wanted susceptibility results in order to treat. And they actually found that it significantly reduced the amount of urinary tract infections, or I shouldn't say urinary tract infections because that would be a true infection, but rather asymptomatic bacteria was left untreated. There was a similar group who looked at urine cultures as well, so Belk and company. They actually looked at urine cultures with low colony counts and similarly added a comment to the report saying this probably isn't representative of a significant infection and therefore this is asymptomatic bacteria and likely doesn't need treatment. And similarly, they had a significant reduction in antibiotic use as well. The third example of framing is actually looking at a different type of infection, which is respiratory infections or pneumonias, and particularly for patients who are admitted into hospital. And Dr. Musgrove and company, they actually added a comment to their report to really explicitly explain that we didn't actually find anything that was pathogenic in this culture. And in addition, specifically, there was no MRSA or Pseudomonas aeruginosa, which are two commonly associated nosocomial hospital-acquired pneumonia agents. And what they actually showed by specifically saying that those two bacteria were not identified actually allowed the ICU to reduce the amount of broad-spectrum antibiotics that would have covered MRSA and Pseudomonas. So really great examples in the literature, but again, isolated, single institution studies, but really sort of taking us down the path that maybe there is something more that we should be considering. So a few years ago, Brad and I led a group where we actually looked at the literature to say, well, what else is actually out there? And because it was still sort of early days, believe it or not, there wasn't an ability to do a meta-analysis or a systematic review with a meta-analysis. So we did a scoping review that really just looked at the breadth and depth of the literature that existed. And we're actually in the process of doing an updated systematic review. And the poster was actually presented yesterday by one of our students. And there's been an exponential growth in the literature out there on this topic. So we've got a lot of work on our hands. So the next thing is we actually, specifically given what the literature was showing us, we actually wanted to take a look at this and see if we could tease out in a more controlled fashion how these different nudging strategies may actually influence prescriber behavior. So we are a group, we're called NIMBLE, so it's Nudging in Microbiology Laboratory Evaluation, and we've started this vignette trial. So we are comparing different ways of reporting the microbiology antimicrobial susceptibility results, and we're comparing it to baseline. So baseline is sort of what Brad expressed earlier, like every lab has a different baseline of antibiotics that they report. Could be a long list of antibiotics, could be a shorter list of antibiotics. Typically, I would say very commonly, all the antibiotics are reported alphabetically. And so what we're trying to do is to compare prescribers' choice of antibiotic based on modifying that report to only report a selective group of antibiotics, so reduce that list of alphabetically listed antibiotics to maybe one or two choices, framing it by, okay, you can still get your alphabetical list and laundry list of antibiotics, but now we're going to add a comment to the report to tell you which one we think is the preferred agent, or you still get your laundry list, but we're going to mix up that laundry list. And we're not going to give it to you alphabetically, but instead we're going to give you the top two choices or the top three choices at the top of that list of susceptibility results. So this is sort of a quick example of how we designed our study. So it's a survey, it's an online survey. We developed a vignette, provided a lot of clinical information to really provide the context in which a clinician, and all the information that a clinician would need in order to make an informed decision to prescribe antibiotics. And they would get randomized to one of the 4 different reports. So either they would get their antimicrobials presented to them as a baseline report. So you can see in the first, on the top row there, it's alphabetical antibiotics. Or you would get the selective report, which is really narrowed down to 2 antibiotics. Or framing, you'd still get the same list of antibiotics alphabetically, but with a comment. And then eye level, we, again, just to demonstrate as the example, the 2 antibiotics of choice are at the top of the list. So we welcome everybody to participate in the survey. QR code is up there. Yesterday was also next to our poster, so if you'd like to participate, please go ahead. Part of the survey, one of the other pieces to it is that we're actually doing focus groups as well in order to get a better understanding of clinicians' perspectives. How do they feel about being nudged? Did they even know they were being nudged? The best nudge is one that you don't even know. So that's what we're really aiming for. And then based on the results of both the survey and our focus group, our next step is to plan a trial where we can actually implement these different strategies in real time to see, does it have the same impact in real life? So I'll hand it over to Brad to sort of summarize everything for us.
So in summary, I think we've shown that human rationality has its limits. We're not entirely rational beings. Nudging is rapidly emerging in the field, healthcare as well as specifically antimicrobial stewardship and diagnostic stewardship. And we think that nudging is an important strategy, but should be considered in combination with other proven strategies like guidelines, education, perspective audit, and feedback to improve antibiotic use. And our NIMBLE research program aims to help optimize nudging in the microbiology laboratory to support stewardship and help mitigate antimicrobial resistance. So with that, we'll close, and these are our email addresses. We're happy to answer questions if there is time.
Yeah, I think we have time for a few questions for sure. Questions in the audience? Oh, someone's coming to the mic.
Hi, that was a great presentation. I have a question. How would the nudging approach work in cases, let's say, if sepsis where rapid access to antimicrobials is important, or in the case of multi-drug resistant bacteria, would there be a use case in those scenarios?
Do you want to start?
Oh, yeah, I think there is generally some rules around the appropriateness of when to show certain antimicrobials. I know that if you can look at CLSI as one example. They have some guidelines around how to report antimicrobials. And one of the things that is stated is that if there is resistance on the panel, you should show it. You should not hide the resistance. So that will be one way of kind of addressing that, is that you want people to know if there's resistance. But you don't necessarily want people to see the buffet of options when one or two reasonable options would do.
And maybe I'll just add to that, I think with any stewardship program, right, it's in collaboration that's multidisciplinary. And so when you choose your selective antibiotics to report, if you're to adopt that strategy, then it might be that with your stewardship group or with your ICU, that if you know that it's an ICU patient, that you may choose a different selection of antibiotics to display as opposed to maybe a patient on the ward. So it does become very tailored, and I think that's the idea here, is to start getting to more sort of personalized medicine. I hate using that term, but I guess that's the genre of the day, to sort of direct therapy appropriately.
Other questions from the audience? Can I ask a quick question? I suppose I'm on the stage and have a mic, so I'm forcing my way in. I'm remembering some conversations from last year about pairing stewardship in the microbiology labs and how that interaction works, and how sometimes it works well and sometimes it's a bit more challenging. And also thinking about different settings where you do have a really embedded stewardship program in your health center or your hospital, and where maybe you don't. Have you guys worked on and thought about these different settings where you have stewardship programs to work hand in hand with versus places where you don't have those stewardship programs, and how the microbiology lab can start to become an embedded place for stewardship in those places without guidance, or as formalized a guidance structure?
Yeah, so I think that's sort of where we ultimately want to take our work, which would be to inform guidelines, right? So right now there is still quite sort of variable recommendations that exist. So if you look at CLSI, they have some recommendations on how to sort of maybe cascade antibiotic reporting. There's also other guidelines that are around that might suggest something slightly different. I think what we're trying to do with our work is to try to create something that's a little bit more systematic and that could be more universally applied, so that there is some consistency. So if you don't have a microbiologist, or if you don't have the resources, that there are at least some basic guidelines to follow that would be consistent across multiple laboratories or facilities as well.
Yeah. Great. Thank you both so much for your talk. And yeah, I'll invite Larissa to
Step away.
exit, but Brad is staying. He doesn't get to leave just yet.